Ghaliah?
Okay, I prepared some interesting cases, not very complex, but at least because I learned from these cases, so I wanted to share these. Okay, this is the first case. So he was a military guy, 21 years old, coming with this ECG. He had a rhythm that is competing with his sinus rhythm, and this led him to a significant hypotension, not able to do activities. He was already in peripheral hospital loaded with amiodarone, but it didn't suppress this arrhythmia. This is the behavior of this arrhythmia. He had the normal ejection fraction. He had, as you see, a rhythm that's competing with the sinus rhythm. Here you have the sinus rhythm, which start to command the heart in this piece of segment, and then the VT goes on, and I'll show you the Holter also. This is again the same guy, so we were in conflict what to do, especially that one attempt of ablation was done for him, but was unsuccessful, unfortunately. Somebody was thinking about putting a pacemaker to overdrive the sinus and suppress this VT. This is the behavior with Holter, what was happening. He was having runs of tachycardia that were persisting and going slow, behaving exactly like an eccentric SA node in the ventricle. Again, this is the ECG. What we did, we went to MAP, of course, and we did really devastating MAP, because where we ablated and found an early activation, it wasn't successful, so we continued to MAP from all sides. I will not go more in details. This is the film of the whole procedure. At the end, what we did, it was just going aggressively on the earliest activation. You can see we went even to the left side, even epicardial, to see what's happening. At the end, we could ablate just above the hiss in a very aggressive manner until we subsided this VT in the patient. Until now is doing well. Here you can see and appreciate all the VT was going, and the patient was going to significant hypotension during this rhythm that is coming over the sinus rhythm. Of course, here the maneuvers are important to have a very good contact. The focus was extremely deep, and maybe we subsided this VT with 50-watt irrigated catheter. So sometimes you shouldn't give up until you get these types of VT. And you see here you have some irritative with the manipulation. This patient now, he's totally healthy without any medication, and he's doing well in his life. Okay. This is all the maps that we have to create until we get to the best activation on this side, just above the hiss, as you see. And it seems like exactly a nodal characteristic tissue that migrated in the RBOT and started to do these arrhythmia. I believe from the congenital point of view that PVCs of RBOT are just migration of these specialized cells to the outflow. Maybe this is part of this. It's not a disease myocardium that caused this focal VT that was warming up and warming down. This is the ECG after ablation. The QRS didn't change. The RBB, which is present, was present even before ablation. And this is when we did ablation and determination. You can see we were not really, we were barely early, but it wasn't easy to find these signals and to insist on ablating these signals. About fascicular VT, we had, I personally, I grown up in these cases with the cases that presented to our center. Of course, as we know, it's usually idiopathic. Sometimes a patient come with a decreased or myopathy induced by this fascicular VT that seems to be occasionally persistent. And the most common type that we saw until now is left posterior vesicular VT with a right bundle branch block and the left axis deviation, as you know, left anterior vesicular VT that come from the anterior vesicle, and this is usually we see more PVCs than a VT coming until now coming from the anterior vesicle. Also, you have an upper septal vesicular VT, and this is really naughty because you can sometimes you can differentiate it from supraventricular tachycardia, and this type of VT, I saw it in two cases of some sort of myopathy. One of them was postpartum, and one as a young guy. One of the nice papers, that described some good study group of 120 vesicular VT, and they defined their approach and their success rate and the recurrence, and it was a good informative paper. Of course, as we know what's happening in the vesicular VT, that we are going to see what is the delay that happens in on the conductive system that is below the His, until we find this gap that is happening that maybe is causing the VT. We have to study more and more and wait until we induce and see what we are having. I will show you how we started this. Another nice picture that shows you how during the VT you are seeking the earliest signal minus the VT from minus 30 to minus 100 even, but usually I seek from minus 30 to the mid diastolic potential, so I calculate what is it. So this guide me more when I can be satisfied with the potential that becomes early during activation map if we are lucky to have the VT. This is another nice picture, took it from the article, how we are positioning our catheters. Usually the approach is retrograde. It's not easy to go transeptal to this, to the septal side, because you need to map the conduction system starting from the His, going down to the fascicles and starting to draw. Also, maybe eyes could help you, because the papillary muscle is one of the structures that may little bit obstacle your path in mapping. So you have to remember that you have to consider going below and above on lateral and complete the map although the presence of this structure. Okay. Another concept that we have to know, then this was in the European Society of Cardiology paper, that the fascia, it's not just one pathway that may cause the fascicular VT. Sometimes the division of these pathway, and you may block one of them, but still this VT can go because of there is other branching of the fascicle. So at the end, we have to insist that we don't have any inducibility. It's not just by terminating the clinical VT that we have it in the lab. Okay, this is, for example, a case, as you see in ECG. I'm showing you the stepwise approach that we learned over our cases. So this is, again, a vesicular VT, a 31 years old male patient who came with this tachycardia. It's narrowish QRS with right bundle branch block, and negative in inferior lead. Again, what we do, it's just starting with calm, doing all the conduction system that we can identify, going in both fascicles, the anterior, and you have to remember that the fascicles may branch to 4 and 5, and it's not just 2 fascicles as was defined anterior and posterior as our knowledge, but they start to branch. So we go and follow, and we spend good time to see all the conduction system. In that time, I was just delineating the conduction system and inducing the VT. And after induction of the VT, I see how early I am regarding the activation of that I have the local activation during the VT, and I ablate. As a target, I was happy already with termination of this VT, but this was not enough. Although this patient he's doing fine now, but I'll show you again and again what we learned later. Okay, here you can see also how we are delining from the His to the fascicles to the Purkinje that come near to the QRS, and then we start to see something like this delayed. I'll show you different cases now. Still fascicular VT. Here, of course, as I told you, I was happy just with terminating the VT. It wasn't really inducible. If I struggle to induce this VT, I already have the pace map of this fascicular VT, although it's not always accurate, but at least if I struggle to induce any arrhythmia or even the absence of PVC, I create for myself a plan and B in case that I can't have the same VT, and we start to identify the best area which matches our clinical VT, and we wait there and try to induce until we get it. This is another case with the fascicular VT. This is an ECG taken from our system. As you see in this tracing, we start to see the tag all the conduction system. See what's happening here. This is becoming delayed until we go to the Purkinje. What we did here, we tried to induce. See what happens here. It's becoming early on the VT. So there was another clue that we found even during sinus rhythm that I started to observe. It's very nice, a delayed Purkinje. So in that second that I have this delayed Purkinje after the QRS, although here there is left bundle branch happened and here there is a normal QRS, this persists with the same duration. So this is for us already is a diseased conduction system that jumped out of the alignment of the conduction that happens through the LV. So in this exact point, we wait and we try to induce. What happens? The same in the same spot, the same Purkinje potential becomes significantly early and becomes even earlier if you go and do further activation map. Okay. So this is already a good clue that we started to observe in the recent cases. So just don't be happy with only delay. But even if this Purkinje come inside the QRS or later, this is a good spot to study your VT and terminate it without spending more time. And this is a nice slide that show in the same slide the same potential that is delayed here coming very early on the VT. So it's already a good spot that we can go ahead and ablate. Okay. This is how we are considering the window that we are interested to see an early activation on the fascicles that are critical for this VT. And we, as I told you, we draw all the conduction system according to the signals that we read. Once I see this delay that's happening, I just wait and induce the VT. And recently, most of the time, this is the critical point for terminating the VT. In this case, we didn't wait here because the VT was again inducible with shorter QRS and even a little bit different morphology. So in this case, we assume that the VT became even in a more proximal re-entry. So we start to go retrograde, and maybe you can use a 3D mapping tool like Interray or HG-Grid, although it's not easy to have a good map without high arrhythmogenicity, because usually these are small hearts. This is again another case that in this we added the HG-Grid and we start to understand more and more. This is a case that we had the VT re-entry here, and then we had another VT that is re-entering, as I told you, in a more proximal part. So see here what we are seeing here. Again, we are seeing these very early potentials and becoming also very early for the VT. At the same spot, we had these delayed potentials, and we had this, a row of late potentials that shows that we have a disease multiple Purkinje fibers. Okay, this is not very accurate picture taken by our technologists, but at least it shows you how we have a multiple delay that is read by the HD grid, and it shows that we are on a diseased area, so you don't need to go and search more and more and try to induce UAPT if you are lucky. About the fluoroscopic approach, I found I try a lot until I have the best grip of the piece or the segment that we have. But one of the best approaches is just going back and looping and going to the area of interest and moving septal or lateral. But at least it gives you a good contact, and because this approach going through the retrograde and just being hang on the septum is not easy to manipulate and to give a good stability. These are the different approaches that we are trying to have. This is another case that came with this type of VT intermittent. She was not responding to flecainide, neither beta blocker, and she had significantly highly symptomatic palpitation. So this is an outflow, as you see. This is one of the cases that is challenging. Of course, somebody described this case as a wide complex tachycardia. We didn't know at the beginning was this case, but later they contacted from the peripheral hospital with this ECG that was taken from the screen. How we plan in this case, usually, of course, we are going to the targeted area. I wasn't lucky to find this ECG before, but we went inside and we started to induce, to understand. We did a complete EV study. At the end, the ventricular stimulation induced some outflow VT. So again, we define our morphology exactly, and we start to go during sinus rest because it wasn't persisting to the outflow. And in this case, until I find the best pace mapping with the help of our people in the EP system, we just wait there. I introduced the HD grid that give you a fast activation map with these short VTs, and we try to induce until we see the earliest spot. Of course, this will take from you some seconds, and you need only few beats of the VT that doesn't persist to define which is the earliest. Here is showing you what's happening during the mapping, and once we induce the VT, how it shows you the earliest activation spot that was already defined by the ablation in advance with the pace mapping. So you are saving time and you are going more accurate rather than having the VT and you are far from the segment that you are interested to ablate. Of course, we went ablation in this site and it was successful. This was done just 1 week ago, so we don't know what's the follow-up until now. The good thing about Oman that we are like a mirror, so any failure is coming back to us because it's only one center. So this is a privilege that I didn't find any place. So we continue to learn from our failure and mistakes. This is another case. I think here I will terminate my presentation because this is idiopathic ventricular tachycardia that was involvement of the septal, but I think I will stop here. Okay.